Dear Facebook Pure Urology viewers, good evening one and all. Like every other alternate day, today we are doing the subinguinal ligation of the varicocele microscopic. As you all know, the varicocele is very common surgery which is performed for the infertility in male patients, where we see common problems like people will perform laparoscopy easily, but that is not the gold standard. Lot of people perform with normal eye that may miss some of the veins or may damage the arteries. So the most latest is subinguinal the microscopic ligation. For that we requested Dr. Raghavender Kosgi, who is concentrating his career on andrology and got also training for the same. Now I will take brief career of the Raghavender and then officially introduce and then hand over the program to Dr. Raghavender. Raghavender, hi, good evening.
Hello, sir. Good evening.
So Raghavender, after your MBBS MS, where did you do?
From Gandhi Medical College, sir, Hyderabad.
MBBS?
From Siddhartha, Vijayawada.
And MCH?
From Andhra Medical College, sir, Vishakhapatnam.
Vishakhapatnam. So MS, who was your mentor?
Dr. Mahbub, sir, during general surgery.
General surgeon. And MCH?
Dr. Chodishetty Subbarao.
So you belong to which batch MCH?
Took 11 to 14, sir.
11 to 14. Very good. Very rapidly you have concentrated on transplant and andrology, and you are presently working at Asian Institute of Gastroenterology, na?
Yes, sir. AIG Hospitals.
AIG Hospitals, which is one of the reputed largest hospitals of the Hyderabad. So when did you develop interest in andrology? During your MCH or from beginning, or just because endourology is practiced by many you don't want it to practice?
No, sir. To be honest, I have a passion towards andrology in second year of MS General Surgery.
Oh, very good.
So I asked my professors, so how it will be to practice andrology as a subspecialty.
Yeah.
Then they were without clue what to do and what to tell me.
Yeah.
But later on in MCH, somehow I got association with Rupi sir, so that I developed my association and passion towards andrology. So that slowly I went into andrology as a
Andrology. Very good. So with this question, I will introduce his CV and then we'll hand over the program to Raghavender. So today topic is microscopic varicocele subinguinal repair. Dr. Raghavender Kosgi, he is consultant microsurgical andrologist, urologist and sexual dysfunction specialist from AIG Hospital Gachibowli. He is a proud winner of gold medal in urology and is one of the few urologists to practice exclusive andrology and men's health in India. He is one of the few andrologists from India who completed microsurgical training in Weill Cornell Medical Center, Cornell University, New York, USA. He completed his andrology laboratory training and comprehensive semi-analysis and advanced sperm production test with renowned Dr. Ashok Agarwal at American Center for Reproductive Medicine, Cleveland Clinic, Cleveland, Ohio. He has performed more than 1500 various endourological procedures, more than 200 kidney transplant surgeries, and around 250 microsurgical varicocelectomies, more than 500 sperm retrievals. He is master of many prestigious international organizations like member ISSM, SASSM, AUA, IAU, ESSM, USI, IMA, CSE, PI. He has delivered lectures as an expert speaker at various national, regional, and international academic forums in the field of andrology. So good interest and as an youngster taken up andrology and then concentrating. We will be happy to listen you the surgical technique related things about subinguinal repair, microscopic ligation of varicocele. Over to you, Raghavender, please. Thank you.
Thank you, sir. Thank you very much for the wonderful opportunity. So, hello everyone. I'm always inspired by Dr. Chandramohan sir for his dynamic activities. Who has started his career and has become an expert laparoscopist. We started with early skills, which I know. So very rapidly he's progressed in endourology as well as in laparoscopy. And wherever we go, I went to Nepal as a speaker for andrology session where are you from Hyderabad? Dr. Chandramohan. They were telling like that. So such a recognition he has got in a very short span of time. So I congratulate you, sir. So I congratulate you on this wonderful virtual surgical training session, which is helpful for many younger generation urologists. So which is very helpful to learn the skills on a virtual background wherever you are. So with this, I'll proceed to today's topic, microsurgical subinguinal varicocelectomy. The learning objectives may be with definition, etiopathogenesis, diagnosis, and management. So as you well aware, what is varicocele? Dilated, tortuous, palpable, pampiniform plexus of veins. And why we are interested as a urologist. So this is a most common correctable cause of male infertility. Out of various reasons, this is the one by fixing the varicocele, we can reverse the pathology so that we can help many couples who are desperate. And if you leave it like that, it will progressively declines the fertility of an individual. So coming to the etiopathogenesis, the crux of the story is a reflux of the blood which leads to raised scrotal temperature, which causes in various ways Leydig cell dysfunction, Sertoli cell dysfunction, as well as venous hypertension causing a reactive oxygen species, which ultimately leads to sperm membrane, lipid peroxidation, or DNA fragmentation and abortive apoptosis, ultimately leading to reducing the fertility potential of an individual by various means. So as you are well aware, these are the patients may present with, majority of the patients are asymptomatic. Some patients may present with scrotal swelling. Occasionally, few patients may come with dragging or aching pain in the groin or the scrotum region. And you can see some patients with visible bag of worms and the affected scrotum will hangs down. So on long-standing cases, testicular size may be reduced, ultimately leading to fertility issues. So how to diagnose a patient with varicocele? Even today, with sophisticated investigations, physical examination is a gold standard procedure for diagnosing a varicocele. Why only physical examination? So this physical examination is important to identify a patient with significant varicocele. So the patients with physically where we can see that varicocele or palpate that varicocele, those patients will do better with surgery. But that is the reason still physical examination is a gold standard, even though it has got limitations. It should be done in a standing and supine position with Valsalva maneuver. And there is a dubinamular varicocele grading, grade 1, 2, 3, as you are well aware. I'm not going into the details. And this is what an handheld Doppler, which I use in my clinic. So to identify a reflux in a standing position. So with the forced Valsalva, I can hear the sound. So if you send one patient with a varicocele to 4 or 5 different urologists, radiologists, they'll give different reports. Standardization of the radiology colleague technique is very, very important for the better outcomes. So as a tool for you, it will help you to identify the reflux in your clinic on a standing position, which is a academic device. You can use it. So what is the role of scrotal ultrasound? Whenever there is a inconclusive physical examination or in case of re-evaluation of the varicoceles. So why is that inconclusive physical examination, especially in morbid obesity individuals, very tight scrotum, or some patients won't allow you to examine because of their sensitive nature, or if case of previous inguinal scrotal surgery or high riding testis, if it is associated with hydrocele where you cannot palpate the varicosities, or objective documentation of the varicocele prior to therapy, or in case of recurrent varicoceles or persistent varicoceles. And you should understand testicular sonography cannot substitute a thorough physical examination. So in my clinical practice, after having a thorough examination, as well as with handheld Doppler, so I'll reconfirm with a scrotal ultrasound, which goes in favor of the EAU guidelines. So what are the indications for varicocelectomy? Clinically palpable varicocele, subfertility, plus abnormal semen parameters. In case of testicular atrophy, where there is a 20% testicular volume discrepancy is there, or at least 2 ml discrepancy on both sides, or in patients with chronic archalgia. These are established indications, but evolving indications when there is a high DNA fragmentation, high oxidative stress, or some patients with hypogonadism or in case of non-obstructive agiospermia. Still, there are no standard guidelines for these cases. So when you are counseling your patient for varicocele repair, you should understand. So it is a cost-effective treatment for male infertility. So the primary goal to upgrade it to normal semen, allow natural pregnancy, or at least sperms adequate for an IUI. In case of a non-obstructive agiospermia, allow ejaculated sperm for ICSI. At least upgrade ART success rates, and it is beneficial in some hypogonadal men. Even if there is a still non-obstructive agiospermia is there despite your surgery, but it will enhance the sperm retrieval rates. So these are the things probably we need to tell our patients whenever we are offering surgery. So what are the various options? It can be a surgery, open retroperitoneal, inguinal, microsurgical subinguinal, laparoscopic, percutaneous embolization, sclerotherapy. It can be an antegrade or retrograde. And there is no role of medicines. Whenever you say there is a patient with varicocele, they'll ask, is it can be managed with medicines? So there is no role, only an adjunct we can use. And as a bypassing method, you can use an IUI IVF for ICSI, where majority of the fertility centers are doing the same thing because of not available andrologists. So there is a meta-analysis of randomized control trials of various surgical procedures. The current evidence indicates that microsurgical varicocelectomy is the most effective and least morbid method among the 3 varicocelectomy techniques for treating varicoceles. So mini incision microsurgical subinguinal varicocelectomy is a gold standard procedure where you can see a testicular artery of 0.5 to 1.5 mm is identified here. Very tiny lymphatics are identified under magnification, and this is a small incision. So the whole success story of microsurgical varicocelectomy depends upon the preservation of the internal spermatic artery. So that spermatic artery, the testicular artery, which gives more than 70 to 80% of the blood supply to the testis, if you are damaging by some means, your results are not going to good. So in some cases, immediately we'll identify the artery. So once you go in, so if it is superficial like this, this is the type 1. Or if it is a type 2, it is just adherent to the larger veins. In case of type 3, it is completely encircled by the multiple veins, which is a challenging dissection for you to preserve this artery. So coming to the steps of the microsurgical procedure, it can be anesthesia. Usually I do in spinal anesthesia as a daycare, or it can be a general anesthesia. Rarely I tried in few patients with local anesthesia backup with sedation. And the second step will be an identification of the external inguinal ring, subinguinal incision, ligation of the external spermatic veins, delivery and opening of the spermatic cord, identification and preservation of the internal spermatic arteries, lymphatics, and ligation of the internal spermatic veins, and wound close. So this is an operating setup where I use a Joyce microscope, where surgeon should stand and its neck should be straight. Otherwise, there will be a neck pain. You cannot do prolonged surgeries, and your hand should rest without any hanging movement. So there will not be any tremor. Usually, any tremor, minor tremor, is also magnified under microscope. So this is first step in identification of external inguinal ring by the scrotal invagination. So we can mark it. This is our incision point. So after marking the incision, so hardly 2 to 3 centimeters incision, you can open the layers. Both layers of subcutaneous fascia, where fascia camphor and Bowie knife. You can use a curved hemostat to lift the subcutaneous tissues. and dissect it further down to the inguinal canal. After that, you can use Langenbeck forceps to further spread up to the spermatic cord on both sides. Mark Goldstein uses Zerni's retractor as well as he uses his index finger to open the inguinal canal to identify the cord. Once you are up to the spermatic cord, if it is visible, then you can use Babcock's forceps. So your visible card is visible here. So next video, so you can lift the card with Babcock's forceps. So once card is lifted with the Babcock's, you should see on both sides and under surface of the card to look for any external spermatic veins or any floor veins, perforating veins running parallel to the spermatic cord. So majority of the cases, people will miss these external spermatic veins, and at the same time, in case of embolization also, they cannot embolize these external spermatic veins. Even in laparoscopy, we will miss these veins. These are located subinguinally. Here in this case, we can see external spermatic veins are not present in all the cases. Maybe in 50 to 60% of the cases, we can find these external spermatic veins. Here you can see the vein. So we have to isolate it. And we can ligate it. Once these external spermatic veins are ligated, you can use 3O or 4O silk, or it can be 4O vicryl. So once external spermatic cord veins are ligated, then I'll deliver the cord with curved hemostat. There are various people will follow different methods here while lifting the cord. Mark Goldstein uses two Penrose drains. One is proximal and other one is a distal one. With the two Penrose drains, he'll lift the spermatic cord and he'll dissect. And you can use Knelton's catheter instead of a curved hemostat. Like Rupinshaw, you can dissect completely in the inguinal canal without lifting. So the primary story here is, if you lift the cord, the artery is compressed, so that it is difficult to identify the internal spermatic artery. So if there is a difficulty in identifying the internal spermatic artery, after this step, after opening, so I can go ahead with papaverine or Doppler. Even still there is a difficulty, I lift this curved artery and I'll put it in the inguinal canal, and then I'll observe for at least 1 to 2 minutes to avoid that compression. So by lifting the cord with the hemostat, it makes surgery easy. So here I'll show you how to use the intraoperative Doppler to identify the artery. Where the 18 megahertz stroke mini Doppler intraoperative Doppler. You can hear the sound of the internal spermatic artery. Now just I have shown all the steps of the procedure. Now I'll show complete video of the procedure and another surgery. So you can see step by step here in this video. So I'm delivering the card where I have used back of the forceps, and I'm opening the external spermatic fascia and internal spermatic fascia. And you can see the vessels. In this case, it is easy to identify the artery. It is a simple case of microsurgical varicocelectomy, where I'm measuring the vein diameter and ligating with 4 silk. So if you want to make sure, you can remove the segment of the vein to avoid recurrence or recanalizations whenever there is possibility. And you can see in this case, there is a one more artery. So we are operating subinguinally. It is a challenging procedure. The reason is subinguinally, internal spermatic artery divides into branches. You have to identify the multiple branches. And even veins are multiple. Here you can see the lymphatics. So at the end of the procedure, you should see an internal spermatic artery, lymphatics, vas and basal vessels. After end of the procedure, you have to run the spermatic cord in your finger under microscope with 20x magnification almost. You have to scan the entire spermatic cord. If there are no veins, probably we can close the cremasteric fascia. Routinely, I don't deliver testis and ligate the gubernacular veins. After closing this fascia, again it will be back to the inguinal canal. It is hardly 2.5 centimeters incision here. So I'll show you another video. Varicocele surgery is not always easy like this. This is a complex case with inflammatory changes. Here directly I'm showing the step where you can see it is a very large external spermatic vein, highly inflamed edematous tissue. So, and other thing, after opening the spermatic cord, you can see how complex it is. It is very difficult to dissect. Sometimes even it takes even half an hour to 40 minutes to identify the artery to dissect it separately. So this surgery took almost 2.5 to 3 hours for me, only one side, because of this challenging dissection, where you can see the arteries identified with Doppler. See that multiple veins are there, completely edematous tissue. In that there is an artery. After half an hour to 40 minutes, I have separated that artery at the end of the dissection. You can see this. Inside there is an artery in this. Microsurgery is nothing but we need to have a patience. Patient surgery will help our patients. So this is a surgical aspect of the microsurgery. So complications will be there is a chance of injury to the internal spermatic artery even with all the sophisticated equipments, and there is a possibility of recurrence or persistence of varicocele, hydrocele formation, and there is a scrotal hematoma, and very rarely infections. In the last 500 cases, I have never seen any infection in any patient. So what are the various procedures? Then there is comparison from the EAU, antegrade sclerotherapy, retrograde sclerotherapy, retrograde embolization. So you can see the complications and recurrence rate. So scrotal operation, usually people, older people used to do. Even I have seen 2-3 cases where scrotal surgery was done, but we should not do scrotal operation. There is a high chance of damaging the testicular artery at that level, and it leads to atrophy of the testis. I have seen patients coming with after scrotal surgery with atrophy, and open retroperitoneal ligation, laparoscopy, and various comparisons here. So why only one particular procedure, out of which microsurgical inguinal or subinguinal varicocelectomy has got least recurrence rate, and it is a least morbid procedure. So in selective cases, varicocelectomy in case of non-obstructive agiospermia, this is not for all the cases. Whenever there is a biopsy report is available, if it shows hypospermatogenesis or it can be a late maturation arrest, sperm may return to ejaculate in 10 to 15% of the cases, and the advantage, it will avoid a TSA procedure and chance of natural pregnancy, even though it is very minimal. So whenever we are offering Varicocelectomy for non-obstructive agiospermia only in selected cases. So there is a systematic review and meta-analysis, but still it needs further evidence. And subclinical varicocele. So all the guidelines are very clear. EAU, AUI, ASRM and SRMU, they don't recommend subclinical varicocele surgery. And adolescent varicocele, whenever an adolescent with small testis, at least 20% difference or 2 ml, less than the contralateral, abnormal semen parameters, if he is able to give semen analysis, and symptomatic varicoceles. So this slide is important for us as a urologist. In 2009, Evers and Collins, there is a meta-analysis where they have shown there is no role of varicocele for fertility. So, but the same group in 2012, these are gynecologists and fertility specialists. So 2012 Cochrane collaborative data, 10 prospective RCTs including 894 men. The same group concluded that varicocele repair beneficial for natural pregnancy. So sometimes occasionally we do varicocelectomy to improve the ART, improve the sperm retrieval rates. There is a meta-analysis, even though these are still needs further evidence for these cases. And how to manage with recurrent varicocele. The most common reason for recurrence is missed internal spermatic veins. Other reasons may be external spermatic veins, gubernacular veins, or cremasteric veins, even though it is a controversial in many of the cases. And surgeon's experience and skill, and whether it is a microsurgical surgery was done or non-microsurgical surgery. So how to manage these patients? There are no clear-cut guidelines. If it is a previous subinguinal microsurgical varicocelectomy, maybe percutaneous embolization is an option. If embolization was the previous surgery, probably redo subinguinal microsurgery. Microsurgery can be an option or vice versa, but guidelines are not clear. So in case of recurrent varicocele, this is an important classification which was given in 1983. You can understand classification, Bahrain's classification. In 0, there is no reflux in grundle vein. In 1, it is a single vein. So even if you ligate with laparoscopy, this single vein, there is a success story here. In case of type 2, if you ligate this vein, we will miss on these things, collaterals, communications. So there are high chance of recurrence. You can see this type 3, this can join here or it can join here or again it can join here. If it joins here, if you ligate only one, so probably there is a high chance of recurrence in case of retroperitoneal either open or laparoscopy. And there is a 4th type, you can see that multiple communications and directly it is joining separately. And the 5th type where there are 2 gonadal veins or internal spermatic veins separately joining the renal vein and double renal veins are there here. So these are the cases where we will miss, and this is the reason other retroperitoneal laparoscopy procedures or embolization, there is a high chance for the recurrence. So what are the guidelines are saying? So treat varicoceles in adolescents with ipsilateral reduction testicular volume, still evidence is weak. But the definitive indication is treat infertile men with clinical varicocele, abnormal semen parameters, and otherwise unexplained infertility in a couple where the female partner has got good ovarian reserve to improve the fertility rates. Varicocelectomy may be considered in men with raised DNA fragmentation with otherwise unexplained infertility who have suffered from failed assisted reproductive techniques, including recurrent pregnancy loss, failure of embryogenesis, and implantation. Still, the evidence is weak. It is evolving indication. So the take-home message, varicocele is the most common correctable cause of male infertility. Diagnosis is by physical examination. Clinically palpable varicocele with abnormal semen analysis is the well-established indication for surgery. Subinguinal microsurgical varicocelectomy is the gold standard procedure. Varicocelectomy is also beneficial for selected cases of non-obstructive agiospermia, hypogonadism patients with raised DNA fragmentation and raised oxidative stress. So thank you. Thank you very much.
Thank you, Raghavender.
Thank you, sir.
I appreciate for that very crisp. You finished in 30-35 minutes, which is our desired time. So we will ask quick questions, around 10 questions, and then conclude the session. Number 1, If you have operated previously varicocele subinguinal, if there is recurrence, is there any role of laparoscopy, or you have to go through the same subinguinal approach?
So, sir, if it is a previous subinguinal microsurgical varicocelectomy is done, in those cases, I prefer embolization, where they can do a venography, they can identify any collateral channels. So that is one option. If patient is not going for embolization, or if there is no facility for that, or trained intervention radiologist is not there, you can go ahead with an inguinal procedure in case of subinguinal. If still some gap is there, probably you can go a little bit further down. But there is no
What
role
is
of laparoscopy.
the role of
Just now I told you in case of laparoscopy where we ligate proximally, still we miss the veins.
What about the varicose veins which are present below the sanguinal region in the post-operative ultrasound, which is very common? For example, if you have done a very good, nice digation of all the veins, that means after 3 months there should not be any veins dilated should be seen in the Doppler ultrasound.
No, sir. Post surgery. So first of all, routinely we don't do post-op Dopplers. The reason here, if you ligate the veins, we are not taking it out. These are dilated veins still left inside the scrotum. So that blood will be there. They will be visible even after 3 months, 6 months also. But we should look for the reflux. Is there any reflux on the scrotal Doppler? So if reflux is there, probably we'll consider we have missed some major veins. If it is 3 months, maybe after 2 to 3 years, maybe recanalization is a chance. But post-operatively, we see these dilated veins, so we'll not consider as a recurrence.
Generally, when you ligate one or two veins, suddenly you don't see any vein in varicocele repair. And if you put finger and roll also, you don't find any veins except very small veins by the size of the vas vessels. Do you think that you have to ligate those veins also?
No, sir, I ligate vasal veins whenever there is a recurrent case, or in case after ligating all the veins, if vasal veins are dilated more than 2.5 to 3 mm, very large, there are two sets of vasal veins, out of which at least one set we can ligate and one set we can leave for the return flow. So not all the cases. Only in recurrent cases or intraoperatively, if I see there is a large vasal vein on both sides, at least I'll ligate one.
Some people do after subinguinal repair, they will bring the testis outside, they will see the gubernacular veins, they will see some more veins on the testis. Are there same veins and they will be appearing again and again? Is there any point taking out the testis after the ligation of these important veins at subinguinal region?
Routinely, personally, I don't do, sir. The data came from Cornell only, where Mark Goldstein does regularly the delivery of the testis, and he ligates all the veins and also the gubernacular veins. And if sometimes you can see external spermatic veins in that location. But from the same group, there is another study from Ramaswamy and Peter Schlegel. They compared Goldstein group. They don't have any comparison group, but Ramaswamy and Schlegel, they have control group. So there is not much difference in the outcome. If you deliver the testis, you have to give a little bit larger incision, and post-operative edema and pain will be more. So I deliver the testis and try to look for the gubernacular veins or any other external spermatic veins. In case of recurrent varicocele, or if I see very high grade varicocele, in those cases I'll deliver and I'll look for other veins.
Okay. Do you have any chance of injuring any nerve during this surgery if you are careless?
Yes, sir. Definitely, we can injure ilioinguinal nerve, or it can be a genital branch of genitofemoral nerve. So once we go into the inguinal canal, these are outside the spermatic cord. Once we lift it, we have to sweep it away with a gauze piece so that we can do our surgery within the internal spermatic fascia.
So there is no point going outside the spermatic fascia at any point of time.
While dissecting the cremasteric muscles and cremasteric veins, probably we should be careful because we'll breach that contained zone. During that time, we should be careful. So, and it's very difficult even under microscope also to identify the nerve. But whenever we are operating, even under spinal, sometimes patients will complain pain whenever you are touching that zone.
Okay. In bilateral varicocele, lot of times we see grade 1 varicocele in right side, and we don't have ultrasound. You are specialist, so you do it. So you mean to say that the reflex is should be documented before you go for surgery than casually going for bilateral varicocele repair?
So in case of one side clinical varicocele, opposite subclinical, you are saying, sir?
Yes, yes, a little bit like that.
So any case, most of the times, if you operate only on one side and if you leave subclinical varicocele on the opposite side, so I have seen patients where they come with an augmented flow on the opposite side, and they'll come with again grade 1 or grade 2 varicocele in 3 to 6 months. If one side clinically palpable varicocele with opposite subclinical varicocele, I'll counsel the patient for bilateral varicocelectomy.
Okay. So post-operatively, the hydrocele people say in theory, but very less often we see hydrocele. What is your opinion? Hydrocele prevention. How can you do? Of course, you told lymphatics and everything should be spared. They should not be ligated. Any other thing like should we avert the tunica and then leave it or something not necessary?
If in cases where we see some varicocele is associated with hydrocele, in those cases we'll deliver the testis and we'll open the tunica, and I can avert. Usually I don't avert. If it is a small hydrocele, just I'll take a small piece of tunica and I'll cauterize the rest of the area, so that there will be some opening for that. If it is a large varicocele, routinely we do, and most of the times hydrocele surgery it should be avoided because it
Oh,
leads to an epididymal chronic epididymitis and epididymal blockage unless until there is a need. And
okay.
as you said clearly, it is a lymphatic preservation. At least one or two lymphatics we have to preserve during surgery so that hydrocele may not be a issue.
Okay. If the previous history of testicular biopsy, such things are done, is there any change in the method of approach towards the varicocele or not necessarily?
So most of the times testicular biopsy is done for an agiospermia. So
Yeah,
routinely for non-agiospermic patients, they don't do biopsy.
yeah.
Previously, some centers they were doing this biopsy to look for ultrastructure of the scrotum, testis, what is happening in these patients. But nowadays, nobody is doing routine biopsy for varicocele patients. So, if that non-obstructive agiospermia patients, if biopsy shows, as I told you in lecture, if there is an hypospermatogenesis or late maturation arrest, those are the cases we can go ahead with the surgery. So sometimes even I do along with the varicocele surgery simultaneously I do biopsy. If biopsy report is not available and patient is convinced for the surgery, simultaneously I do. But that doesn't make any change in my management towards the surgical approach if previous biopsy is done.
My last question. During venography, how it is performed, can you explain? You might have seen. We don't have idea how the venography, which vein is used, how they inject anything.
So this is some same routine percutaneous embolization procedures are where they'll go ahead from the femoral vein, where they same route they'll go in and up to the aorta and access to the gonadal vessels. From there they'll inject contrast. They'll see that is one way. And old methods where Murmur performed the first microsurgical varicocelectomy, where he has ligated and approximated both the proximal and distal Penrose drain and the spermatic cord, and he used to give injection to that one of the largest vein so that he can see under X-ray. So it is a routine venography like other embolization or
In
radiographic
sensitive,
technique.
you can see nicely the veins.
Yes, sir, that is visible, sir. So that communications we can see, even though I'm not expert in reading those communications, but we can see those communications.
So good interventional radiologist will block them.
Yes, sir. So they'll block at main point. They'll try to block. So coming to the embolization, the limitations I'll tell you why embolization is not popular. In 20% of the cases, they cannot access the internal spermatic vein, and right side procedures are difficult for them. And external spermatic veins, it is very difficult for them to access. So these are the reasons embolization is not good. But in well-established centers who are performing regularly these procedures, as I told you, in recurrent microsurgical varicocelectomy, there is an embolization option. But in good hands, it is also an option. So varicocele is one surgery where many options are there. Depending upon the skill and availability of expertise, it is good to go ahead with any procedure. So instead of doing a wrong method microsurgery, doing a non-microsurgical method is better, because if you go ahead with attempting the microsurgery, you will injure the artery in the subinguinal location, which is little bit complex without any training. So if somebody wants to learn microsurgery, probably they can go ahead with an inguinal approach first. Just have to open the external oblique fascia, so that veins will be less, artery is easily identified, it is little bit separate. After 4-5 cases, probably they can come down to the subinguinal location.
Dr. Siddhalinga Swami has asked what is the diameter of the vein which you consider is very much abnormal ultrasound for varicocele to be labeled.
So the threshold of the vein, still no guidelines are there, but it is 2.5 to 3 mm vein diameter. There is a clinical correlation in 70 to 90% of the cases with reflux, documented reflux.
One more question from the Udayatullah is that do you ligate gubernacular veins?
Not routinely, as I told. In case of recurrent varicocele, I'll deliver and I'll ligate if there are there.
Very nice. You are on fire and you answered questions quickly. It shows your knowledge and very quick and very precise session. Very, very useful for the juniors. Your second surgery has shown clearly. Which microscope you are using, Raghavender?
It is a Joyce microscope, sir, where ENT surgeons are using routinely that microscope.
How much it will cost roughly?
It is a Joyce one. It is costing around 20 to 25 lakhs, sir. But there are other options where there is a fine vision is there, which costs around 5 to 7 lakhs.
What is that 5 to 7 lakhs mission company?
Fine vision, sir. Microvision or fine vision is there.
They are microscopes.
Yes, operating microscopes, sir.
And the Joyce one is how much magnification you will get maximum?
25, sir. This which I am using is I'll get 25.
Oh, do you have any strain when you have spectacles or myopia or hypermetropia?
No, sir. During microscopy, even you don't require spectacles. Also, just we need to identify adjust our interpupillary distance, IPD diameter distance, as well as you can adjust. Then it is a rotatable eyepiece will be there, so that your neck should be straight.
This is used primarily for the tympanic surgeries here.
No, sir. This is a separate microscope I have. They have other microscope, ENT people, and even neurosurgical microscope is there. That is also different microscope. There are high-end microscopes from the Joyce company. Neurosurgical is cost around 5 crores maybe here, and ENT one it costs around 1.2 or 1.3. Sir, I am using a lower version for this andrological purpose.
Very good, excellent information. Thank you very much, Raghavender. Wonderful session. Very crisp.
Thank you, sir. Thank you very much.
Thank you very much.